I invite Dr. Subudhi sir to talk on rough roads converting Phaco to SICS. When and how?
A warm good morning to all of you. Again, I pay my regards to Dr. Devasis. 30 years back, I had been to his hospital to learn SICS. Today, I'm standing because of him. So, thank you, sir. As you know, the Phaco is usually common surgery now seen in the youngsters, but many times we have lot of complications, lot of problems during Phaco. So, only way to get out of these complications is the SICS. So, you must learn SICS simultaneously with the Phaco. So, I thank AIOCMTC2 for giving the opportunity to stand before you. You know, Phaco surgery is a highly skilled surgery with a long learning curve, and complications can occur at any stage of the procedure. But the post-operative vision is very much compromised. So, in contrast, SI is a very simple technique with short learning curve and very few complications with excellent visual results at par with Phaco. So, as you know, complications can occur at any stage of Phaco surgery, but SICS comes to rescue. So, SI is the best friend of Phaco. So, these are the instances where you can land in complications. So, starting from the improper case selection, CCC-related problems, excess use of Phaco and fluid, wound-related problems, corneal edema, intraoperative and most common being the posterior capsule rupture, which is the worst complications one think of. So, these are the things. I don't want to go into details about the improper case selection. Already it has been discussed by my friends. A hard cataract. We have seen already some of the nuclear techniques, removal techniques shown by Dr. Devasis. These are the cases where you must think that primary surgery should be SICS, not Phaco, because you will land in, whether it's an experienced surgeon, but the beginner also will land in complications. So, CCC related problems, yes, small CCC, big CCC, again, a big problem for Phaco. And as you know, excess of Phaco, if the hard cataract you use more Phaco time, that leads to complications. And fluids also, if you don't balance the fluid, if your instrument is not very good enough, it's not an advanced Phaco instrument, you will land in complications. So, intraoperative meiosis, yes, in old age patients, our patients are very much elderly people. So, meiosis is one of the most common complications we see, whether preoperatively or during surgery. Somehow accidentally if you touch the iris contracts, and the people become small and you land in all complications. PCR is a very common, complications we fear of. In any stage of the disease, there is every chance, if not done properly, carefully, you land in PCR. And once the PCR has occurred, everything changes. So, at once PCR, you notice at any stage of the disease, best back out, convert yourself. So, these are all, instances where you can land in PCR, and I don't want to go to details. However, some of the stages where you can land in complications, like again during hydrodissection, if forcefully introduce fluid to separate the nucleus, again the posterior capsule, thin posterior capsule give way, even also weak posterior capsules, this gives way and you can land in the PCR. So, once you notice that there is a PCR, these are the three basic indications or three major indications where you have to convert when the posterior capsule rupture, then errant capsule rhexis, and of course, it's a hard nucleus, a dense hard nucleus. These are the three instances you have already encountered that you will land in complications. Better to convert yourself to Phaco. Can you play the Phaco video? See here. So, this is one of the, immediately we have noticed that there is a PCR. So we extended the incision and tried to remove the nuclear pieces. Already the nucleus is divided into 2-3 pieces. So, slowly you remove the pieces by your Vectis, taking careful not to damage the endothelium, not to disturb much of vitreous. Already vitreous is in the wound. Remove that gently, the pieces are removed gently, all the pieces are removed. Also, some of the cortical matter have been removed. And whatever the vitreous is there in the wound and in the antechamber, remove them with a Vanna scissor. You can use the vitrectomy instrument also. But if you are master, you can do anything. If your vitrectomy instrument is already ready with you, you can go for vitrectomy instrument. Otherwise, you can do with a Vanna scissor. Remove all the vitreous, make the antechamber and wound very clear of vitreous. Now you can place the lens. It's a PMMA lens has been put, though you have planned for the foldable, but you should be ready with the PMMA lens too. So in this, there is no compromise in the results. Our main aim is to the interest of the patient. So how to make the transition? So whenever you notice that you have already ruptured the posterior capsule, don't remove the Phaco piece. Wait for some time. Simultaneously from the side port, inject visco. Maintain the interchamber so that there will not be any collapse. Then second, any nuclear pieces are there, you remove them carefully. All pieces must be removed. Then, of course, once you notice the PCR, whether it is a small one, a large one, and how much vitreous is disturbed, whether it is still the vitreous is inside or it is already exposed to the interchamber, and that changes your management. Then steps to convert, already I explained the things. Inspect the interchamber for any vitreous prolapse. You can remove the vitreous. Already I mentioned, I've shown with your banana scissor, but you can better if you can go posteriorly, remove all the vitreous coming from the behind. It will vitreous will well managed so that no vitreous will be there in the wound, and your wound will be perfect. And if your posterior capsule is intact, and you can still inject a foldable lens, you can give it, or you can go for the single piece lens. Also, you can, if you are not very sure that how much posterior capsule is left behind or anterior capsule left behind where you can support your lens, better you should plan for a second-time surgery, secondary surgery. Maybe you got a lot of things are now available in your hand. You can go secondary IOL by either the iris fixed lenses, scleral fixed lenses, even very good interchamber lenses also can be given simultaneously later. So our aim is to give the best visual result to the patient in spite of having a large complication, what you have seen. So IOL in the bag, if the PC rupture is small and out, is one of the best thing you can happen. If you can see that the small posterior capsule rupture there, better to give the lens in the bag. Bonus tips: while extending the section, please do not compromise that and do not be confused also. You extend. You see that how much the nucleus is hard, how much extension you should be doing, so that at least you will have much complication later, and post-operative results like astigmatism can be minimized. So let our ego, because we have counseled the patient for the Phaco, and we have taken so much money, so much whatever thing, but whatever may be the instance, your ego must not come in your way for the larger interest of the patient. So I will request all of you to learn the SICS and convert. Whenever you find an opportunity, whenever you find a complication which may compromise the patient's results, better to go for a conversion and adopt the best technique at present, that the SICS. Thank you very much.